In this video, the authors present a technical note on making use of a patient-specific 3-dimensional surgical guide for the anteriorizing tibial tubercle osteotomy. The authors have no conflict of interest to disclose. A computed tomography scan of the knee is performed for preoperative planning. From the CT cuts, a virtual 3-dimensional model of the patient's tibial and fibula is reconstructed. The osteotomy cuts and angles are then planned out on this model. The coronal cut is planned to be made at 1/3 the distance from the anterior to posterior cortex of the tibia to preserve the integrity of the posterior cortex. The plane is determined by drawing a line across the midpoints of the medial and lateral tibial plateau. An 85mm cut is planned to be made from distal to proximal before angulating anteriorly to make an oblique cut of approximately 20mm. 60mm of length between the tibial tuberosity and hinge point will be set aside for the insertion of 2 screws, which are planned to be inserted at 20mm and 40mm distal from the tibial tuberosity respectively. After discussion and review within the team, a physical prototype of the jig and 3D model of the patient's tibia, fibula, and section of the patella tendon is printed out. During the final planning session, a go and no-go check should be performed for the attachment points and cutting slots with the K-wire and a saw blade. The final jig is then printed and sent for sterilization. After being put supine and under general anesthesia, a longitudinal incision of 20mm medial to the tibial crest and inferior to the joint line is performed. Soft tissue is carefully dissected and releases are performed to enable the jig to sit securely onto the tibia bone. 3 2mm K-wires are then inserted as planned on the jig. The osteotomy cuts are then made with the saw, using the jig as a guide. Constant irrigation with saline is given during the saw cuts to prevent overheating and osteonecrosis. Under gradual distraction, anteriorization of the tibial tuberosity of 10mm is achieved. Intraoperative fluoroscopy is used to ensure the integrity of the distal hinge. A femoral head allograft is then prepared and inserted into the gap. The TTO is secured with 2 cannulated screws placed in an interior to posterior direction. The tourniquet is then released and hemostasis is performed. The wound is subsequently irrigated and closed in layers.